a very precise topic. How do I use MRI for doing RFAs? Now, it's not MRI for diagnosing or not MRI for prognostication or not to decide whether to ablate or not, but how do I use to ablate? So how does it change my practice? Now, we know we all have changed our practice from practicing only entrainment-based VT ablation. Now, when we talk about MRI, as Dr. Kumawat in previous talk said, that for atrial circuits, for atrial flutters, atrial substrates, MRI is not good. At least till now, the 1.5 and 3 Teslas that we use, it's not good to discern the atrial scars. The walls are just 1-2 mm thick, so it's not good. But for ventricles, it's very good. So that's why when we talk about integrating MRI for ablation, I'm talking about integrating MRI for deciding what the strategy should be for ablating ventricular substrate, like ventricular tachycardia. I'm not talking about using MRI to integrate the LA map for AF ablation. That's a separate thing. So we are talking about ablating VT. There lies the importance of MRI for doing RFA. Now, we all have moved from the era of doing only activation-based ablation. Otherwise, we don't need MRI. We just need to go there and pace from every site and do activation-based ablation. But there are downfalls of doing activation-based ablations. You can't just target just one VT, one clinical VT. How many VTs are you going to target? It takes a long time. These patients are sick patients, 20-25% EF. They can't be in VT for a long period of time. And secondly, if you are just ablating few VTs and not addressing the scar, it's like it has been said, you're just killing the messenger and not finishing the war, which is the actual arrhythmic substrate. So and it has been conclusively proven that substrate-based ablation are a better modality. So what MRI gives you is an information about your main thing which you require, your substrate. So what are the models of VT that we have? We have a fixed scar model. That is what we base most of our electrophysiology on a fixed scar model. So all the entrainment circuits, all the Dr. Stevenson diagram, and everything is based on this model. Then you have a refractory model in which there's a differential ERP and anisotropy, altered gap junctions because of myocardial infarction. And then there is interstitial fibrosis resulting in displacement in between myocytes. So there is a conduction delay. All these information will not be given to you by a plain electroanatomical map. Now, you can do ERP-based mapping, but then at every point you have to find out the ERP of the tissue. It's not feasible. Secondly, what are the drawbacks of our using only fixed scar-based model? There are many things which you don't know, or there are many things which are not explained by fixed scar model. For example, how do you explain unidirectional block every time? Secondly, how do you explain that many times what has been found that the line of conduction block bordering the isthmus is not actually a chunk of conduction block, it's a line. And there's no physical presence of that line. It's basically changing ERP around a slow conduction zone and a fast conduction zone. And that gives you a line of conduction block across the isthmus, which you see in the diagrams. Third thing is the source sink model. Now, this is also a very interesting and important model, as not all circuits which open into an absolutely good viable chunk of myocardium can depolarize that myocardium. So you need that sloping kind of a myocardial bridge between the diseased tissue and the healthy tissue, which can help to make your electrical signal conduct to the normal myocardium. If there is immediate conduction, the strength of the current inside that narrow isthmus is not enough to depolarize the whole healthy myocardium. So there's a source sink model also that explains a lot of times why not all isthmus or not why all surviving myocardiums which are connected to normal tissue give rise to these tachycardias, why only some circuits are involved. So what we do in EP mapping right now, we are just doing voltage mapping. And what does voltage tell you? It tells you a few things. First of all, it tells you, is there a scar or not? Though it is not very good, we need to validate it more. Secondly, it tells you how's the conduction, if it is slow, if it is fractionated, how's the underlying tissue, all those things it tells you, but it tells you very little about the refractory model and the source sink model and all these things. Yes, you can extrapolate those things seeing the EGMs, but that is very complex and you can't, computer can't do it. The computer can't make it a map for you. So there lies the importance of MRI. So defining the substrate is the Achilles heel of doing a substrate-based VT ablation. While you are doing EP-based VT ablation, I know it's very nice to see late potential in lava and ablating them, but how good are we over there? So let's see. The limitations of electroanatomical mapping, it's a non-transmural part of scar remains undetected. All you are seeing is a signal, bipolar signal. Point summation of all the voltages are shown you at the endocardium when you're doing a bipolar mapping. And heterogeneity of scar is not displayed. For example, the tab which is shown over here, just a minute. Yeah. Yeah. So this thing, the catheter tip which is lying there, it will show you summation of everything that's on top of it. It won't show you if there is a scar, if there is a isthmus, the heterogeneity, the transmurality, all these things are not shown. And a 75%, 80% transmural homogeneous scar is completely different from a heterogeneous scar with differing signal intensity with same transmurality. So the chances of isthmus is high in one and 0 in other. So that information is not giving you by contact force. That information is not giving by plain electroanatomical mapping. So another thing, correlation between channels and isthmus is not very strong. There are few papers which say that the voltage channels that you get by adjusting the voltage margins in a substrate map may harbor isthmuses, but there are many papers to counterprove it, that your isthmus actually lie in the dense scar. It actually lies in the border zone between the dense scar and the voltage, so-called stipulated voltage channels. So what channels do actually we want to see? What is the threshold of, like Dr. Kamal was talking about, I tell my technician to keep threshold just above the noise level. Actually, he's correct. I mean, that's what Dr. Hiroshi and many people have shown, that even 0.03 is not dead. Even non-capture is not dead, for that matter. You can have VT ablation by ablating in an area which is electrically unexcitable. So those papers have also been published. So we know that defining the substrate based on just measuring the voltages is not good. But we can approach those areas still by ablation, because you know your ablation reaches far more deeply than what you're sensing on the endocardium border. So imaging can provide this missing link. So how can MRI help me during ablation? It can make you more effective, more efficient in mapping. It can make you more fast by doing targeted mapping. If you know where the scar is, you will just go and use those, map those areas. It informs you whether endocardial or epicardial technique is needed. It tells you the border zone channels, where the channels are. So again, you can map those areas more carefully for presence of isthmus. It tells you about the isthmus, those areas which have been scientifically validated by doing electroanatomical and MRI-based mapping for those isthmus sites. It can tell you where is the most likelihood to get isthmus. And secondly, and last of all, it can tell you about source sink mismatch, which is just not possible with the other modalities. So let's start it one by one. Scar and fibrosis localization. Now this is very intuitive. We all know that scars can be seen on MRI and they can be displayed. So subendocardial or transmural scar, they predominate in acute MI. So it's epicardial vessel ischemia, which leads to subendocardial infarction, subendocardial and sometimes up to transmural. So most of the times, why we are successful doing only endocardial mapping is because 80% of all the scar that happens in the myocardium is projected onto the endocardium. So most of the times, what the scars are there on the endocardium. So it tells you, but sometimes, like the case which has been shown here, your endocardium bipolar voltages are quite good, whereas your unipolar are conforming to the presence of scar in the MRI. So your MRI tells you the extent of scarring. So scar and fibrosis localization. This is another case, electroanatomical map. It is showing that this area is negative. There is nothing there. I mean, it's a healthy area. Negative, when I say negative, I mean there is no exciting thing present there. It's a normal tissue. But still, if you see MRI, you see that there is a scar there. So it's a false negative. If you see the MRI picture, you'll see there's a scar there. Similarly, there can be false positive. Your electroanatomical map is showing green area. Green means borderline scar up to 1.2, 1.5 millivolt bipolar. Whereas in MRI, you see it's completely healthy. There's no scar. So what the problem was your contact force. So most of these places, if you go again and you map carefully, you will see signals there. So these false negatives and false positives and the other contact issues can be dealt with just as soon as you look at the MRI. So scar and fibrosis localization, how do we do that? How do we merge? So the merging is very simple. You in CARTO or in NAVIX, you go in the left main and you do left main registration. It's the fastest way of registration. You can also use aortic annulus, you can use mitral annulus, but they are pretty, takes slightly longer time. You can use 2 sites also, but the left main registration is the fastest, and even a single point registration is good enough. So you can overlap these 2 map. Now, when we are talking about MRI, we are talking about signal intensity. MRI doesn't know electric signals. It just knows signal intensities. So your MRI data, which is in raw format, is in signal intensity, has to be coded for 2 things. We are interested in 2 things: scar transmurality and scar heterogeneity. Now, how this signal intensity is coded into these 2, I'll just go in 1 or 2 slides. So now we are talking about channel identification and heterogeneity of scar. So this is how your MRI tells you about how heterogeneous your scar is, the thing which I was talking about. It's not a uniform scar. Now if you see on this panel, the heterogeneity, the signal intensity is shown between 190 to 120. Now this is gadolinium enhancement. 120 is the least intense signal presence in the normal myocardium. And 190 is the most intense signal present in the scar myocardium. These 2 are your extremes. Now, based on this, you can calculate your normal tissue and your scar tissue. So what borders you take? So scar is defined as myocardium with signal intensity more than 35% of the maximum myocardial signal intensity, and was subdivided into core scar, more than 50% of the maximum, and border zone, that is more than 35% to 50% of the maximum. So below this is all normal. So by this, you can make a core scar and you can make a border zone scar. Now, these are not arbitrary things. They have been validated by doing previous studies, animal studies, and even human studies, and correlating with the electron anatomical map scars. And they have been found to be valid. And signal the SI threshold can also be, there's another method of using standard deviation. 3 standard deviation high is a scar, and less than 2 standard deviation is normal. And 2 to 3 is border zone. So you can use either. But most of the data which is there is with the core scar, more than 50% of the signal intensity, and 35 to 50 is border zone. And this is how you see in the map. This all is absolutely dense scar. The green area forms the channel. Now, these are the channels which harbor the isthmuses. And what it is showing you viable myocardium and dead myocardium both. And it is not just showing you in one plane, it is showing you in 3D. I'll just show you how. So this is the electron anatomical map. The thresholds over here is 1.5 and 0. So you can see anything purple is healthy, anything red is a scar. Now, this map doesn't make sense. You don't know where to go and where not to go. Whereas if you see this electron anatomical map, the channels are pretty much visible. But it's not visible here, and let me tell you what the cutoffs are. The cutoffs is 0.3, 0.3. Sorry, it is 0.2, 0.2. It's not visible to me also. So it's 0.2 and 0.2. Maximum 0.2 and minimum 0.2. So what do you see is anything above 0.2 millivolt is now pointed as healthy. Anything less than 0.2 is pointed as scar. So now you are seeing these good voltages. But if you go by traditional modeling of 0.5, all you will see is a scar. Now you will think, okay, so I will keep on reducing. That's what we do normally. And that's one way to get these data without using MRI. But the problem is, what scar settings to keep to see these channels? There is no validated data on this. What scar settings, like Dr. Kamal was saying, there is no lower limit. What scar settings will you keep? Now, MRI is very good over here, that the scar settings which are there in MRI, the transmurality, it is something which is very unique to a normal myocardium and a scarred myocardium. There's not much variability. And because it is in 3D, and because it is pixel by pixel calculation, it is much higher resolution than your electron anatomical mapping. And you see this kind of data. And this is a binomial data. This is not, this is just border zone and core scar zone. And you see a beautiful central isthmus channel. And this you will see every time if you do this. So you see a dense scar and you see a heterogeneous scar. So this is your border zone channel identifications. You can use this. And if you see what is the difference, if you take two groups of people who have substrate, that is post-MI scar, and who have VT, versus post-MI scar and who never had VT, what is the difference between the substrate? You see that this border zone and heterogeneous tissue channels, how frequent they are in these group, in these patients who have VT. 88 to 90% occurrence in the VT group versus only 20%, 30% occurrence in a non-VT group. So this is a very good way of seeing the heterogeneity in a scar. So what is the, again coming back to the point, what is the limitation of EAM-defined channels? Now, this channel has been defined by MRI as to be heterogeneous and to be able to harbor an isthmus. Whereas this channel is defined by a EAM, electron anatomical map, which we normally do in our labs. Now, the difference between this channel and that channel is we don't know what settings to keep. At 1.5 and 5, everything is a scar. At 0.3 to 0.25, we see this channel. If we go further down at 0.2 to 0.15, we see this channel. Now, what is the adequate channel? What is the adequate setting? That is the problem with this model. But anyways, till the time we don't have MRI fusion for everyone, we can use this technique. So this is the problem. The culprit, the scars that show channels to you, you don't know which is the culprit channel. So culprit channels, they reside in the area which has a heterogeneous critical mass, above which the circuit can form and below which the circuit cannot form. So we'll just talk about that critical mass. So what are the other drawbacks? VT channels can be there without VT. Isthmus. For example, you see a channel over here in the VT, in the electroanatomical map, but the isthmus is far away. So the channel is here, isthmus is here. And these are EP guided isthmuses. You can see here S to QRS, concealed fusion, mid-diastolic potential, everything is there. So these isthmuses are far from the channels. So there will be no point connecting these two things. So one thing is very clear, conduction channel is not equal to isthmus. So coming to then, how do I identify isthmus on MRI? So there are two things. Till now we were talking about the scar heterogeneity. Now we will talk about transmurality of the scar. So isthmus identification is aided by MRI by seeing both the things, transmurality as well as the heterogeneity. So isthmus depends upon both heterogeneity and transmurality. I'll show you. So yeah. So if you see the transmural area, most of the isthmuses, 100% isthmuses in this study, they lied in the transmural area, which the transmurality was more than 75%. And the signal intensity was around 50 to 75%. So signal intensity should not be near 100% of the scar, because that is too dead an area. And similarly, the signal intensity should not be very low, less than 50%, because that is too border zone an area for an isthmus. Isthmus is critically slowly conducting, so it has to be diseased enough, but not too diseased also. And most of the times, these critically slowly conducting areas are found in the dense or in the transmural scar. So the transmurality should be high, but the density of that scar should be low. So what we come is, and similarly, you don't go in the core of a scar. It's very difficult to find a isthmus bang right in the smack in the middle of a scar. So if you go too deep, then too deep is too dead. Most of these isthmuses are located in a transmural, more than 75% scar, and heterogeneous scar, but they are not too deep, because it has to go out and connect. If it is so slow conducting and too deep, it won't be able to come out. So too deep is too dead for a VT. So, so what we are looking for is high scar transmurality and a limited scar density. Now, if I just show you these two maps, you don't need any 3D mapping for this. You will be able to tell in which you will get VT, in which you will not get VT. This is a transmural scar full transmural scar, but there is no heterogeneity. It's a fixed scar. It's a complete scar. Over here, you see heterogeneity. The signal intensity will be mixed. It won't be 100% of the scar. So it will be transmural and mixed. These are the areas which will be picked by MRI and will be told to you that the isthmuses can be here. So now coming to the last part, identification of the source sink. How can you do that? I'll just briefly touch upon this. So you need a shallow sink connecting to a normal myocardium. Otherwise, the strength of the current in that little isthmus will be insufficient to depolarize whole of the myocardium. So this is one hypothesis which tells you how the border zones of these isthmuses are formed, conduction border zones. So for example, if there is a immediate, it's a uniform conducting scar to the all sides. Okay, it's a trapezoid, uniform conducting scar to all sides. But if all the sides are bang normal healthy myocardium, the current does not have enough power to go to the and depolarize the myocardium. Whereas if some sides of the scar have this kind of a ramp effect, where the current can start depolarizing small amount of myocardium and then finally reach the main chunk of myocardium, then the current can build up enough current to depolarize the whole myocardium. So this is a source sink model, and it is very intuitive how MRI can pick it, because MRI is seeing 3D transmurality. So over here you can see that there is an area over here which is the scar is very close to the epicardium. So you have a transmurality which is a very thin area. The other area, beyond that, is a normal myocardium. So this is providing you the sink for your source. So this kind of picture can also be told by MRI. And again, this will again be picked up by the same transmurality and limited scar density model of the MRI. So how to use step-by-step for MRI? Now, I have not touched upon wideband preferred, because most of the times we are doing VT ablation for ischemic VT, and these patients will be having ICD, in which we will not be getting good signals. So for that, we have to use wideband MRI. That will give us good signals. Then you have to tell your radiologist to do a SI-based coding for both transmurality and heterogeneity. It's there with most of the systems. You have to merge it with EAM, your electro-anatomical map, using your left main as an equivalent. Then you have to go for channel identification and isthmus identification based on those areas. And finally, you have to use EP. You have to go there, see the signals, map for the late potentials, lavas, paste from there, see signal to QRS and all those things, and then give the lesions there. But at least it will tell you where to go and look for it and where not to. So careful EA mapping in those areas for late potentials, lavas, etc., and homogenization of a heterogeneous scar by limited RF application. That should be our goal. Homogenizing an already dead core area with signal intensity 90 to 100% won't serve much of a purpose. Whereas leaving some channels which appear to be too dead because the signals were only 0.2 will be a problem. So we have to ablate all those areas. So what is the clinical data if we use MRI for this? Using MRI-guided VT ablation versus non-MRI guided VT ablation, if you use MRI and map it with PSI is pixel scanning integration. So if you map it, if you integrate it with EAM, the VT-free interval is much low as compared to only using EAM, which is kind of explainable. What are the limitations of CMR? The most important limitation is that the late gadolinium enhancement is not very specific for scar. There's some other things for which late gadolinium enhancement can be positive. And secondly, there are some partial volume effects, which is because of signal averaging that can come into the border zone. But those effects are not that pronounced to create that much of a noise as compared to the problems which are there in your electroanatomical mapping. So it's like choosing the lesser problem. So for PET-CT imaging integration, there's not much there to it. It's not preferred modality for integrating or seeing the you can see the viability and see which part of your dense scar is viable, but the resolution of gamma camera limits us for making the precise models. So you can fuse it, but most people they don't do. what PET-CT and CMR is used for is managing inflammatory Vt. I'm just going 3-4 slides for this, not more than that. Again, to thank Dr. Narasimhan's group for the data for this. For MRI and PET, both are very useful for Vt ablation in this subset for any inflammatory Vt. So number one, you have to see scar inflammation, which you can see by T2 weighted images by seeing edema, and by PET seeing the hot scar. And number two is determining the etiology, whether it is sarcoid or tuberculosis. You can do by various methods. So and then you have to do biopsy. If it is a granulomatous VT, then you give ATT, you give antiarrhythmics, you give immunosuppressant. If you're all, most important thing is if like recently, few days back, I think 2-3 days back, we had a case. She's a granulomatous. She had a VT with pericardial effusion. We did MRI. There were some areas of inflammation were there, but her everything regarding TB was negative. AFB stain, TB culture, TB DNA PCR, tuberculin test, the pericardial tap, everything negative. So this is a case which classifies for a sarcoid. So for sarcoid, you need immunosuppression. So conclusion, CE-CMR is very useful adjunct to traditional electroanatomical mapping for guiding our ablation. CMR gives complete substrate information, particularly about transmurality and heterogeneity. Conducting channels and isthmuses areas can be identified for further explorations. And VT-free survival can be increased by incorporating information obtained from CMR to our radiofrequency workflow. And CMR PET scan is essential for inflammatory VT workup. Thank you.